Okay, welcome. Hey, Dr. Khan. First of all, thank you very much for spending Sunday morning with us. I know that's sometimes an inconvenient time, but obviously when you're working, it may be a more convenient time, but appreciate it. I guess are you up in Toronto? Is that correct?
That's right. Yeah.
Yeah, and so just for you, you're a radiologist, and I guess you do interventional radiology as well. Something that, as I was selecting my specialties, I got to tell you, I was torn between orthopedics and radiology, just sitting there, and I thought radiology is a really cool field. It's got some really neat toys, and one of the things I thought that was really interesting, and when I talk to radiology, he says, a lot of people are trying to guess and figure stuff out, and radiologists kind of get the answer because you got the imaging, you don't have to sort of try to interpret things and get the diagnosis. So anyway, if you don't mind, can you give us a little kind of brief summary of your background if you can?
Yeah, sure. So I'm a fully Canadian trained, fellowship trained radiologist up here. I do general radiology in a community hospital, but I have gone through an academic residency program. I've worked in academic centers, done a fellowship. So, I've seen some complex cases, and we routinely see people with metabolic diet-related disease on our imaging, treat them sometimes with interventional procedures. And, a colleague of mine and I that work in the same hospital, we're very passionate about this topic, and we want to kind of show people all the sort of diet-related diseases that, we see all the time that are kind of ticking time bombs for people. And, one day they wake up with a stroke or a heart attack or something, and we want to kind of raise awareness of all the things that we see before that happens so that people avoid that kind of fate.
Yeah, and that one of the that is very stiff with the interventional stuff. You are so often treating these lifestyle. I know when I went in orthopedics, I was like, well, I'm just going to be doing broken bones and taking care of sports injuries and as a general orthopedist. And what it ended up being was I was mostly taking care of metabolic disease, just the orthopedic aspect of it. And I know I don't know what kind of, obviously there's a whole gamut of interventional stuff. You don't do vascular, I guess, but there's
no, I didn't train to do that. But as a community radiologist, we have to do like sort of neck to pelvis. We do a lot of sort of biopsies, drainages, tube insertions into gallbladders that are inflamed, kidneys that are blocked by kidney stones, which is a diet-related disease as well. And then, cancer, that's the other thing, right? People don't look at it as a metabolic disease, but chronic inflammation is, associated with cancer genesis. Obesity is associated with most of our most common cancers. So, really, even when I'm biopsying a tumor somewhere, it is some kind of diet-related disease.
Yeah, that's I think something that is really, truly something people don't understand. Can you look into imaging and how do you see metabolic disease from an imaging standpoint? I know we talk about, blood pressure and, certain lab numbers and stuff like, what do you see as a radiologist when you look into the body? Can you see inflammation? Can you see metabolic disease, and if so, how do you do it?
Yeah, absolutely. I actually have a PowerPoint presentation, and I can show you the kind of skeleton if you want, and we can jump around through it. And I can actually show you pictures, like a little picture show today, if you want to see what we see in terms of metabolic disease.
That would be awesome. Let me enable you to screen share. Give me just a half second. It would be pretty cool to see. I know we've done that with a few other guests before, but so you might be able to do. Let me just make sure you can do that right now.
Okay, let's see if this works. Can you guys see my screen?
I can. Yeah, looks like we can. Yeah.
All right,
perfect. Round table. Absolutely. Yeah.
Yeah. Can you see my mouse cursor too? Because
we can. So perfect. Yeah. That'd be great to check that. Let's check that out.
Okay. So I just want to show people kind of like the horrors of sort of diet-related disease. I'm not intending to give medical advice, but obviously I'm biased. I think carnivore has benefits, but anyways, here's the sort of presentation skeleton. So, we see, leaky gut. You guys have probably heard of leaky gut and how it's implicated in autoimmune disease. We actually see signs of this on imaging. So I've got some examples of that. I've got a little bit about, what foods can contribute to that. And then I have case examples of sort of head to toe almost, neurological disease, brain and spinal cord, heart disease, cancer, and then many GI tract diseases and bone disease, which is, would be your area. I've got a pretty nasty case of compression fractures that are probably diet related to show. So I'm happy to go with whatever you guys want to see.
Well, just start, and we'll interrupt and ask questions as we find. But I mean, this is awesome. I'm really excited. I'm really excited to see the leaky gut seen on imaging. That's kind of interesting to me. Yeah,
you had Dr. Sophia Clemens from Paleo Medicina, and they really, they lean heavily on this leaky gut stuff as the root cause, diet-related cause of so many of our diseases. So for the people that may not be familiar, leaky gut is basically intestinal permeability. So normally our gut is, it's a tube, mouth to anus, but it is a barrier between the external environment, which is whatever you take in through your mouth. There's bacteria coming in, food coming in, whatever you put in your mouth, and your internal environment, which is your bloodstream and the rest of your body, your organs and stuff. So typically, if your gut is healthy, the good stuff gets in, vitamins, minerals, other nutrients, macronutrients, and the other stuff doesn't. But when you have leaky gut, something harms your gut and destroys these things called tight junctions, which are proteins holding these enterocytes together in your gut. And so you can see over here, this is sort of the healthy bloodstream where you've got only the things you want in. And over here, you've got pathogens, food allergens now getting in through the leaky gut. So when your immune system sees this, it attacks it. It's a foreign thing that's not supposed to be there, and it can trigger autoimmune disease. And with autoimmune disease, you get sort of chronic inflammation. So this is, somebody can have this grumbling along for years or decades. It's insidious, and it's a cumulative effect over time. And people just think, oh, I'm just getting old, but maybe there's some of this stuff going on. And on the flip side, when you have unhealthy gut, you're not absorbing things properly. So people will get, bloating, abnormal, sort of abdominal pain, bowel distress, diarrhea, that kind of thing. And then malnutrition. They're not really absorbing all the nutrients that they need from their diet anymore. Some of it's just kind of getting expelled in the feces. And again, that can be a gradual decline over time where people just become more tired, fatigued, feel unhealthy, feel unwell. So this is a image. I'll come back to this in a second. This is what intestinal malabsorption looks like on CT scans. And I see this very, very frequently. As far as some known medical causes of malabsorption, there may be more, but celiac, gluten, grains, Crohn's disease is a disease of the intestines, can cause malabsorption. And if we look at the sort of diets that, even in conventional medicine that doctors recommend to people to treat or help reduce these diseases, celiac and Crohn's, it'll give us an idea of what foods may be promoting these diseases or causing them. And, lactose intolerance is another cause. Medications can cause it as well. So this is what it looks like to me on a CT scan. And, I see this very frequently now that I know what to look for. I didn't learn about this in residency. I learned about this after residency on my own. And, every third or fourth CT of the abdomen, patients coming in for other things, I just see it sort of incidentally. So to explain what this is, so this is down lower abdomen and sort of pelvis. These are their femoral heads. These are pelvic bones. So the bright stuff is bone. This gray stuff is the muscles, so the gluteal musculature, hip girdle musculature, and this darker stuff here is body fat. And in here are all loops of small intestine. And we give our patients something called oral contrast. So it's a fluid that's got iodine in it. So it makes it bright on CT scans. So it, shows basically the contrast of, the intestinal wall versus the contents of the intestine. And it looks kind of like bone, but it's actually just liquid. So you can kind of see there these loops of bowel that are kind of dilated more than normal. They're creating polygons. They're falling against each other. They're sort of flaccid and atonic, and they're unhealthy looking kind of loops of bowel. And one of the analogies that I read about to describe this is sort of like sleepy puppies or sleepy kittens. Like if you can imagine a litter of kittens sleeping together, they're all going to kind of flop. Their muscles will sort of relax and they'll all kind of flop together. So you can imagine the loops of bowel relaxing. So for the rest of the slides, make sure you keep this image in mind. And we call this small bowel conformation. The bowel loops are kind of conforming to each other. And I see this all the time. This is just from the last few weeks. There were even more that I didn't say, but these are just incidental sort of cases of small bowel conformation, signs of small bowel malabsorption. And they say non-celiac gluten sensitivity is 15% of the population, but just based on my sort of anecdotal experience in a community hospital in a small town, I think it's way more, but, we still have to do research to bear that out. And then other things that we see in terms of metabolic disease. So there's obesity, visceral, deep subcutaneous fat that are associated with metabolic syndrome. We get vascular disease. So you're going to see arterial narrowing, arterial calcification, like in the coronary arteries of the heart. Kidney disease, you get shrinking kidneys because of the vascular disease. You lose renal function over time, and the same process affects the brain. So I've got an example of some white matter disease too. And these are like typical routine findings. I mean, our patients that come in for all sorts of things, but whether it's cancer, I mean, they're typically obese. They've got all these signs of vascular disease. They've got diverticulosis. They've got osteoporosis, muscle wasting, arthritis, like you name it. It's just this sort of typical constellation of diseases that cluster together that we just see over and over and over again. And even Dr. Yoganathan, you had him on your podcast. He's a gastroenterologist from Sydney. He even said his patients that do sort of a meat-based carnivore-ish diet, their episodes of diverticulitis become less frequent. So, all these things are sort of diet related, even outside my own experience. So yeah, I mean, do you want me to talk about like what foods may be causative for this, or do you want to go to more case examples of like the actual images?
Well, I mean, it's fun looking at the images, and I'm used to looking at CT scans, and certainly, I'm obviously concentrating on the bones that I'm looking at, but that's pretty fascinating, quite honestly. Yeah, I mean, certainly, let's just keep going. We can talk about the foods. Certainly the imaging is very compelling, and it's interesting to see. So, if you've got if you've got things that you can, I don't know if you can see interventions when you eat food, and you can see what changes you see within the gut or other areas. It might be interesting to see.
Yeah. Okay. So why don't we start with the GI tract diseases, since that's what we opened with, the leaky gut. So you guys can see this, the GI tract disease slide still? Okay. So, I mean, you guys know about fatty liver. So people develop fatty liver. It's associated with metabolic syndrome. And there's this disease now called NASH. So non-alcoholic steatohepatitis. 30% of the US population, so that is a massive number, right? We're talking over 100 million people in North America alone with this problem. And it's just ectopic fat deposition. Your body starts running out of places to put fat. It starts putting it in organs like your liver and your pancreas, and it can lead eventually to, chronic liver inflammation, liver fibrosis, and something called cirrhosis, which is typically associated with hepatitis and chronic alcohol consumption. And it's a rising cause of cirrhosis to the point where in the near future, it'll become the number one cause of cirrhosis in the world, or maybe not in the world, maybe in North America and Western sort of societies. And it'll be a cause for liver transplant. And, we see it very frequently, this disease on imaging. So here's an example of a patient I had. Ultrasound, she's 22 years old, female. She's got an enlarged liver. So we're measuring the liver here. Typically 15 centimeters is our cutoff, and hers is 5 centimeters bigger. This is her right kidney, and this is the liver. So you can see, the liver looks a lot brighter than the renal cortex, and typically they should be closer in appearance. So that's how we can tell. This is actually quite a fatty liver. I would say at least moderate to severe fatty infiltration of the liver. And so she's only 22. So she's walking around like this for years or decades. Eventually it will lead to other things like cardiovascular complications, like I said, chronic liver disease, transplant, and because of the chronic inflammation, cancer elsewhere in the body, but also in the liver. One of the complications of liver cirrhosis is actually liver cancer. This is what it looks like on cross section. So you can see this is like a pasty, greasy looking liver. This is not her liver, obviously, she's still alive, but this is just a gross specimen of what a very fatty liver would look like, and it can lead to liver failure eventually. And then this is sort of the next step in the progression. This is an older patient, 67 years old. She has known NASH cirrhosis. Now, if you're not a radiologist, some of this is a little bit subtle, but you can see the contour of the liver is sort of lobulated and irregular. This is not normal. It should normally be sort of a smooth contour. And then even the sort of appearance of the liver, it's not homogeneous. It's not smooth looking. So we call it a coarsened ecotexture. And this is a sign of all the the fibrosis, the regenerative nodules starting. This is kind of the body's repeated sort of recurrent efforts to repair the damage to the liver. And eventually that turns into, in full-blown cirrhosis. So, the top causes right now are hepatitis C, alcoholic liver disease, which is technically also diet related. And then they say cryptogenic cirrhosis is 20%, but they're thinking most of that these days is due to this non-alcoholic steatohepatitis. And then this is what it looks like on CT. So you can see that kind of irregular nodular contour to the liver over here. And then all these little guys here, these are all nodules, regenerative or dysplastic nodules, which are potentially progressing towards cancer. And this is hepatocellular cancer. So this is a cancer directly related to liver cirrhosis. So kind of a graphic showing what it looks like. And then this is what we see on CT scans, this mass here. And it's actually invading into one of the major veins, bringing blood supply from your intestines to your liver, and causing a clot to form in the major blood vessel there. So pretty nasty stuff. And, this is really, you can't reverse this stuff. You're looking at a liver transplant, and with a cancer like that, potentially death. Other things, we talked about fatty liver. You also get fatty pancreas. So the funny thing is this CT scan here, so this is kind of a cross section through the upper abdomen. You should see the pancreas here, but it's actually completely fatty replaced. It looks just like the rest of the patient's ample visceral fats. This is fat around the right kidney. This is fat around the spleen. That's the liver. These are all loops of intestine, and just like zero pancreas. Like there's just nothing there anymore. And you can see this patient's abdomen. This is now looking at them front on. Their belly is just distended with tons of fat between their loops of intestine. So unfortunate kind of metabolic scenario for this patient. And then they've got other things that go along with metabolic disease. So, gallbladder stones. This is the gallbladder sitting here under the liver. These bright things, this is gallbladder sludge and probably a gallbladder stone. And then this is the left kidney. This patient had many, many more calcifications, but these are renal stones. So probably calcium oxalate stones in this patient. And this is, again, these kinds of things are very common on our patients. This is a young patient. She's only 14 years old, and she came in with obvious GI symptoms: abdominal pain, diarrhea. She was even bleeding per rectum, weight loss, and she had a very striking malabsorption pattern on CT. And we sometimes see people present later in life, like middle age, late life, probably having suffered from this for decades. So I've got this patient here. She came in with similar symptoms, 45 pounds weight loss, bowel change, typically means some kind of diarrhea or change in frequency of bowels. And she's a very striking small bowel conformation pattern, again, with the loops sort of falling together, atonic, no sort of tone to them. And then you can even see the contrast, oral contrast has diluted, meaning that as the oral contrast passes through their GI tract, it's encountering fluid-filled bowel loops, which is it's not a normal state for the bowel to be in. So yeah, that's sort of the GI tract disease. Anything else you guys want to see out of this list?
Yeah, I mean, you said problematic foods. Do you have what are we talking about with that, with the problematic foods?
Sure. Yeah. So I'm coming at this from a purely medical perspective, but we all know, being in the carnivore space, that there's lots of problematic foods. But my logic is let's look at diseases like celiac disease, Crohn's disease, and what do doctors put their patients on to help, reduce a flare of these diseases. So for instance, Crohn's, it's a low residue, low fiber diet to give them bowel rest. As you know, carnivore is a zero carb diet. Stanford did a study on children with Crohn's disease, and their sort of specific carbohydrate diet, which is used to treat Crohn's in children, excludes all these foods. So added sugars, grains and grain products, canned vegetables with added ingredients, legumes, tubers, processed meats. I mean, really, processing is the theme here. Canola oil, we all know industrial seed oils are harmful, pro-inflammatory. Milk and milk products, candy, junk food, obviously. So, it kind of makes you wonder why these foods are staples in the, standard Western diet. Everyone's like, oh, I'm going to eat in moderation. But if you're moderating with junk, you're going to get junk results, Meanwhile, unprocessed meat and eggs are allowed for both celiac disease and Crohn's disease patients. Other things that promote, obesity, metabolic syndrome, we know low protein, high processed foods, high energy content, high energy density foods like, liquid calories, pop, junk food. These are sort of fundamental characteristics of what we call the standard American diet. And whenever I talk to people about how I eat, it's this sort of cop-out, knee-jerk reaction. Oh, I believe in everything in moderation. And, my point is that it hasn't really done us well so far, right, Shawn? I mean, for the last few decades, we've just been suffering worse and worse. All chronic disease is just rapidly increasing. And other things, in the carnivore space, we know industrial seed oils are sort of pro-inflammatory omega-6 fatty acids, which we get way too much of in our diets in the first place. So why add that in? Grains and grain products as well. So, and we can obviously we can get all the vitamins and minerals that are essential to humans easily, in the biggest quantities, most bioavailable quantities from animal products. So why risk, the anti-nutrients and these other sort of inflammatory problems from plant foods, I guess, is the logic for carnivores.
Yeah, I mean, you'd get a lot of agreement within this community on those types of foods for sure. So, I mean, I know some people will say different types of dairy might be less inflammatory than others, but, I think that the atonic bowel is pretty fascinating, that you have this, this loss of tone and I think most of us are aware of the fatty liver and the fatty infiltration and the visceral fat that seems to occur. When I guess the leakiness you're seeing, is that the atony and is that the fluid-filled loops? Is that where you're saying this is where the leaky gut is coming in? Because you can't obviously see the cell tight junctions on. Yeah, no,
it's only sort of gross pathology that we can really see on imaging. So it's sort of an indirect sign that the bowel is unhealthy. So presumably an unhealthy bowel is going to be leaky, right? It's going to be inflamed. And we can even see there's other signs too. This is just the most obvious sign. I've got other examples of cases where you can actually see the mesenteric hyperemia. So it's excess blood flow from inflamed bowel going in through sort of the portal vein system. So we even see edema, which is fluid in the root of the bowel mesentery. So it's sort of like, it's the point of attachment for the bowel. It's typically just clean, clear fat. But when you get edema in there, it's another sign that the bowel is inflamed. So I've got some examples of that scattered through these other cases, because often, people you look at, they've got brain disease, spinal cord disease, heart disease. They've also got gut disease going on at the same time.
Yeah, it'd be interesting to look at some of these other conditions because, obviously there's probably a common pathway for many of these, and heart disease being so common might be a good natural place to segue. And if you've got where you can correlate the gut and the heart or some of these other findings that go with this metabolic stuff and heart disease would be pretty cool to look at.
Sure, let's go there. So I do have some of that stuff. So here's a 54-year-old male. So this is through the chest. And I'm comparing a cut through the chest to a cut through his abdomen. So you can see these are his coronary arteries, and this is calcium. So it looks like bone. For those that are unfamiliar with CT. So this is, pretty heavy burden of calcified coronary artery disease. And when people do those CT scans for coronary artery calcium scoring, this is what we see. I think you had one of those done, right, Shawn? And your results were quite good from what I recall. Yeah, 0. Perfect. So obviously this guy's not 0, and he's not like an old guy at all. I mean, he's like maybe middle age, and he's got a lot of calcium there, and that's got to last him the rest of his life, these blood vessels. And then over here is an example of the visceral fat. So I wanted to compare, look, this is his chest. This is the thickness of his abdomen relative to his chest. So he's got a distended belly because of all of this visceral fat just, interspersed between all the loops of his intestines and his retroperitoneum. It'll be around his kidneys on another slice. And then, same guy, he's got fatty liver and possibly NASH. This is me measuring the density of the liver and relative to the spleen. Typically, they're supposed to be about the same, but here it's almost half the density, meaning, and fat is a low density tissue. So if fat is infiltrating the liver, it's going to reduce the overall density of the liver. So that's just to illustrate that in the same patient. And then this is what I was talking about. So It's a little bit hard to see, but I know this is the superior mesenteric vein, this round, the sort of oval circle here. This is bringing blood back from the loops of intestine to the liver in the portal venous system. And this is his abdominal aorta, and they're almost the same size. So this is not the normal relationship. Usually this is supposed to be a fair amount smaller than this. So this is a sign of excess blood flow from inflamed bowel, bringing the blood back to the liver. And then he's got, like I said, renal stones. So all these diseases kind of go together. Renal stones can be seen in malabsorption type diseases, Crohn's and celiac disease, for example, calcium oxalate being the most common stone. And you guys have all heard about, oxalates and plant foods and stuff like that. And if you, again, look at, medical advice for limiting the formation of kidney stones, they say to limit high oxalate foods. And I mean, good riddance to spinach, right? That's one of the highest oxalate foods out there. So that's it for the heart disease. But you can see all that stuff in a patient with heart disease going on at the same time.
Yeah, I don't. Based on your observation, how frequently do you observe these two things running together? Where you have somebody with relatively advanced heart disease, do you typically, if you get down and cut into the liver, are you typically going to see a fatty liver? Is that, or some of these other GI signs? Is that pretty common?
It's pretty common. I'm not going to say that every single patient that has heart disease or bowel malabsorption has every other single sign that I'm showing, but it's just they tend to run together. Some people have them all. Some people only have a few. Some people only have one, but it's so commonly seen together, Shawn. It's almost like if I open up a CT, middle-aged person, I can see they're obese just from the preliminary scroll through. I can almost imagine what I'm going to see. It's like, it's that common that it's just almost like I could do it. I don't do this, but I could do like a template report of what I'm going to see in advance before I even see what they actually have.
Yeah, and I imagine you can just go look at it in the population and you can probably imagine what their CT scan or MRI or whatever imaging study is going to look like just by looking at their appearance, I would imagine, correct?
Absolutely. I mean, look, I get so horrified by seeing this stuff on my scans so routinely. I see what these patients look like in terms of their external body habitus, and then also on the inside. And then I walk around on the street in North America and I just see exactly these same kind of patients, and they're ticking time bombs. Like I personally don't think there's such thing as a healthy obese person. I mean, you may temporarily be healthy by our conventional parameters, but something is grumbling along, and something eventually will give. They'll develop something in the future, whether it's a heart attack, a stroke, liver disease, stones, cancer. Something is going to happen at some point, and that's why I almost want to jump up and down and shout on a table and tell people, hey, you got to sort your stuff out, or this is going to be you one day. It's happened to my dad. It's happened to friends of friends. People have prematurely developed these horrible diseases, and I really just don't want to see people suffer. But inevitably, I feel like they are going to suffer based on what I see.
Yeah, and as a radiologist, I mean, you have your interaction is a little less than what maybe a primary care physician might have, because obviously you're asked to be a consultant, and they're asking you to do a procedure, whether it's an imaging study or perhaps an interventional study, but you probably don't get a lot of opportunity to do a lot of counseling based on, I would imagine, just the way it works.
It's not exactly in my scope of practice. I mean, sometimes in my reports, if a patient has fatty liver, fatty pancreas, signs of malabsorption, excess visceral fat, I'll actually put in the report, like I can't say, oh, do the carnivore diet, but I put in sort of bulletproof advice, like eliminate or limit processed foods, no liquid calories, eat only whole foods. Like I'll actually put that in my report as sort of an added value service to the clinician. And sometimes the patients even read those reports. And then I also do joint injections. So lumbar facet injections, these are typically overweight patients who've got wear and tear arthritis in their lumbar facet joints that can cause quite a bit of pain. So for those procedures, it's just, the patient's fully conscious. I'm talking to them throughout. So I kind of probe them and I see, like what their, receptiveness is to maybe making some changes. Because sometimes nobody's ever talked to them about what they can do to prevent the horrific pain they're going through and these needles they're getting for the pain. And some of them are open to some advice. I had a patient recently, actually, she told me she had success on Atkins and stuff. So I referred her to some, resources that might help her kind of have more success long term on it, so she doesn't come back with worsened arthritis in the future. So I do get a little bit, but yeah, not like a primary care physician, for instance.
Now let's transition, because I think you had some slides on the musculoskeletal system, if I'm not mistaken.
Yes, I did.
And then I because I honestly believe that much of the typical arthritic disease, as a trained orthopedic surgeon, my training was, overweight, obesity, mechanical wear and tear, but it seems like it's much more biologic, and a lot of the new sort of research is showing, these inflammatory cytokines, which I think probably run pretty closely with what you're seeing within the viscera. So I don't know if you have any correlations between arthritis and are we seeing this same sort of visceral fatty liver, inflammatory gut associated with some of the arthritis cases?
Well, I didn't actually save cases of arthritis, and it's ironic because it's just so common. It's like everybody that looks like this, the patients I've shown so far, has horrible, spine arthritis, lumbar facet degeneration. But I sort of, and I agree with you, there is probably a chronic inflammatory component of that, in addition to just mechanical wear and tear that accelerates their arthritis. They just prematurely get this wear and tear arthritis that, everyone experiences to one degree or another just by being under the effects of gravity over decades. But I have a case of osteoporotic compression fractures related possibly to diet. And, as people know, osteoporosis is complex, but there's a lot of sort of lifestyle and diet related factors. So calcium, vitamin D3, being the obvious ones. Some people implicate low protein intake. Obviously, no weight-bearing activity, being sedentary, that's a problem. If you lift weights, it actually helps build bone. Smoking and drinking are deleterious too. GI tract surgery, so if you cut out parts of the stomach or bowel, you get reduced absorption of nutrients, and that promotes the development of osteoporosis. And then there's all sorts of medical conditions, and you can imagine how these are all implicated in poor nutrition. And then medications, so long-term corticosteroid use. So my example is actually an 80-year-old lady. So this is her CT scan from 2018. So this is viewed from the side, a sagittal image, nice curved spine. And this is actually an impressively good-looking spine for an 80-year-old. Like this, if I saw this scan without a patient's age, I would have guessed this patient is in their 30s. But on the same scan down here through the pelvis, you see that sort of small bowel conformation pattern. So she's got signs of intestinal malabsorption, and even her colon, a little bit hard to show you guys, but she's got something called diverticulosis. So these are little outpouchings from her colon. So again, she's, something diet related is going on that's causing these problems. And then you fast forward 2 years, and it's truly amazing. I mean, this was her in 2018, and then in 2020, just these severe compression fractures in her upper lumbar spine, lower thoracic spine, to the point where it's causing what we call kyphotic angulation. She's going to hunch over, and I can only imagine how painful this is for her. Some patients, these fractures actually sort of retropulse into the spinal canal. So this is where her spinal cord would be. It can actually squish the spinal cord, the nerve roots, cause, bowel and bladder dysfunction. It can cause, shooting pains and numbness down to the lower extremities, the lower legs. So that's her. She's still got, obviously, that small bowel malabsorption pattern. So, it's just, again, there's nothing much you can do about this. I mean, we can send them to an orthopod like yourself and try to get some of this sort of surgically stabilized, but there's not much you can do about repairing this. Once this happens, you're stuck with it for life, and a lot of chronic pain and wear and tear arthritis that will now accelerate through these joints. And it's a horrible way to live the last few decades of your life, so it's really a shame this happened to her.
Yeah, and I know there was, and I don't know, that's amenable to things like kyphoplasty or vertebroplasty, which is stuff that, I don't know if it's still in favor. I was never a spine surgeon, but I know they were messing with that for several years, and the results were kind of mixed. There's a question somebody's asking, this is kind of off topic, but you say you can see calcium oxalate stones in the kidney, as they kind of look like a white, kind of like a bone pattern. Can you see, are you able to see oxalate crystallization in other tissues? Can you delineate that on a study that you can think of?
No, not that I'm aware of. I mean, certainly I haven't seen anything official from like a peer-reviewed journal about that. And I can't really think of anything else in the body where we're seeing that for sure. That, I mean, we do see calcification in other, places. Like sometimes in the brain, there's this part of the brain called the basal ganglia, and we get calcification there, but I can't tell you what the composition of those minerals are. Like it could be a variety of things, and I don't really know what those are made of. And they can be from all sorts of things, like, metabolic disease, but also drug toxicity, people taking sort of illicit drugs. There's genetic diseases that can cause that. So I really, unfortunately with imaging, we can see stuff, but it doesn't come with a label like, hey, this is exactly this kind of cancer, or this is this kind of mineral. You'd have to cut it out of the patient and send it to a pathologist, and then they can look at it under a slide, do chemical testing, and then tell us more detailed information.
Yeah, I'm just it's kind of interesting when I'm looking at this, these sagittal images, on the left of the screen on my side, and you look at the ladies, I don't know if the kyphosis is exaggerating, if it's the same. It looks like it's pretty close to the same section, but I mean, she seems like her gut has protruded more. There's more distension in the belly. Is that? Am I imagining that, or is that actual? Do you think?
That's a good observation. Like, it's certainly there. The contour of her skin is bulging. It's hard to say. I mean, yeah, maybe she's got more visceral fat. It kind of looks like she does, but also the lordosis of her lumbar spine is more pronounced. So, it's probably a combination of both, but I think that's a fair observation that, yeah, maybe she's put on a bit of weight. Even looking back here, her subcutaneous fat, paraspinal subcutaneous fat, look how thick it is there. And then look how thick it is there. And it's roughly the same slice. So I think that's a fair thing to say. She's probably gained a bit of weight as well.
Yeah, interesting. And then I know this is something that's recently come out. I don't know if you're familiar with it, but we see that people that get repeated corticosteroid injections in the spine do tend to have a higher rate of fracture down the road. So that's just something that people should be aware of as they talk about that, because I know we do a lot of those injections are done. But let me ask you, so let's talk about the nervous system a little bit, because
Sure.
I assume you probably got some brain slices. Would be my guess, but
I do, yes. Okay, so this lady is a 45-year-old patient with known multiple sclerosis. So these are MRI slices of the brain. So this is kind of, looking at the brain as if we're sliced kind of like a loaf of bread. And you can see this bright stuff out here, this is the gray matter, the cortex of your cerebrum, which is the top part of your brain. And this is all the white matter. And so multiple sclerosis is a type of white matter disease that attacks the myelin of the nervous system. And the myelin is sort of a fatty, you can think of it as like an insulating coating, like you have on electrical wire. Myelin helps signals in the nervous system conduct better. And the myelin is fatty. And in the brain, especially, DHA, which is an omega-3 fatty acid, is a big component of the myelin. So, people who don't get enough DHA, probably not so great for their nervous system. So this lady has demyelinating plaques. So these are inflamed white matter plaques. These are the ventricles of the brain. So fluid is in these black spaces. And so we get periventricular white matter disease, which is a typical finding in multiple sclerosis. So, in theory, leaky gut can result in a cascade of problems that lead to autoimmune disease, under which MS falls, obviously. Now, I'm not going to directly link MS to leaky gut here because I don't know if the research is there, but certainly Paleomedicina in Hungary, they're pretty unequivocal about this. They think that it is implicated with leaky gut, and even specifically dairy is a problem for MS in terms of MS developing. These are some different slices, a different sequence, just showing some more white matter disease here. This is sort of from the side, a sagittal image. So this is more white matter disease, but this is a very classic sign of MS, like a perivenular, so around the veins in that part of the brain, distribution of or configuration of the white matter disease. So just to go over for MS, we have lots of risk factors, but there are two that I found that are lifestyle related. So one is climate. So people in North America, Europe, similar kinds of temperate climates, and then vitamin D, which is, something that, most of the population is actually deficient in vitamin D3, just sort of walking around their whole life, especially in this part of the world. And this is associated with a greater risk of MS. And I certainly work indoors and in the dark a lot. So, vitamin D is something that's a concern for me too. And most people have very sedentary jobs and aren't really getting in the sun these days in the first place. And then her spinal cord. So she's got, this is her thoracic spine. This is her cervical spine. And it's a little bit subtle. I tried to improve the contrast you can see, but this is another white matter lesion, but of the spinal cord in her sort of mid thoracic spine, that bright thing there. And another bright thing here, kind of in her lower cervical spine. So there's that. Oops, sorry. And then if we look down at her gut, guess what? She's got the small bowel malabsorption pattern. So it's not exactly a smoking gun, but it's just so common and it's, it's there. So it can't possibly be helping her MS,
Yeah, I mean, I think if you look, there's a fellow, I think he's Boston Children's, Alessio Faisano has done quite a bit of work looking at gut permeability and autoimmune connection. So he believes there's this very strong link. So he's another one that's done quite a bit of the research on there. I know I've seen studies, at least animal studies, looking at MS and saying that in the animals that they were able to improve the myelination of the nerve fibers, which you point out are fatty kind of insulation. It requires dietary cholesterol. The endogenous that's made in the liver is not enough to overcome the demyelination process in MS, which is interesting. So, and I don't know if you have any information or interest, but somebody's just asking about spore biotics and helping with gut permeability. Do you probably
probiotics?
Spore biotics, or is there a special type of probiotic? Probably not. I imagine
okay.
that's something you've delved into. Being, that's something that maybe a gastroenterologist might have more knowledge on, but that's just an aside.
Sure. Yeah. No. Just your comment about those nutrients and stuff. I mean, the irony, Sean, is that a lot of the stuff that the brain, the nervous system needs are ironically the things that we're told to eat less of, like eat less cholesterol, eat less fat, eat less red meat, which is a great source of B12 and iron, DHA. So, I mean, that's kind of the irony there as far as that. And then I'm not really, I don't take probiotics. I don't take any really supplements other than D3 and some magnesium. And to my knowledge, we just don't know enough about the gut. It's a very new science. I would defer to someone like Dr. Pran Yoganathan in terms of his thoughts on probiotics. He probably uses them in specific situations, but I just feel like if you eat the right kinds of foods, it will feed the right kinds of bacteria and promote their proliferation, and the other ones will die out without having to, artificially interfere. As humans, I think sometimes there's a bit of, arrogance in the terms of thinking that we have everything figured out with science, and then we go and start messing with the body, outside of sort of natural things that we have had for the last few millions of years, and we end up causing more problems than, solving. So I'm a little bit reluctant to use probiotics for that reason. And I'll tell you just from my own personal experience, I've had a sweet tooth my whole life. I'm almost 40, and just, hunger, food cravings, uncontrollable around sweets. I'll eat 3 or 4 pieces of cake if nobody's looking, and carnivore has completely destroyed that. I just, I barely get hungry. I'm not food focused, not thinking about what my next meal is or how much I'm going to eat. And now looking at sweets actually is repulsive. My stomach turns. So, I asked Dr. Yoganathan to come back to gut bacteria. His theory is that my gut bacteria has now, the microbiome has shifted to a more healthy population that no longer is driving me to eat carbohydrate-laden processed foods and sweets. And now this is kind of normal. For the first time in my life, I have a normal relationship with food. So, I mean, that's as much as I can say about it. But again, I would defer to him for expertise on probiotics.
Yeah, and as I recall from the interview I did with him, he was not particularly all that convinced that probiotics were that helpful. I think, your chronic diet is going to have a huge, much bigger impact than what the probiotics will do.
Absolutely. Yeah.
In my view. Let's see. Do you have any other slides? I can't remember if you had another system, organ system you had in there.
1 second. Well, we didn't talk about cancer.
Cancer. Yeah, let's go talk about cancer. That's a little controversial topic, but
yeah, for sure. Okay. So, again, I'm coming from this from what we know in medical science, just to explain to people that, hey, like this is legit, there's sort of 13 cancers that are known to be associated with overweight and obesity. And some of these are the most common and or the most deadly. Like ovarian cancer is certainly deadly. Breast cancer, certainly potentially deadly. Esophageal cancer is as well. Colon and rectum. I mean, pancreas is one of the worst cancers you can get. And that's the example I have today. So this is a 56-year-old male. Now, like, it's hard to show some of this stuff without scrolling through an entire CT, which I can't really do with PowerPoint, but I tried to highlight the contrast. So this is normal pancreatic tissue. This is the spleen, left kidney, right kidney, liver, gallbladder. And you can see this normal pancreatic tissue suddenly becomes dark. So this is a sign of a mass, something abnormal with the pancreatic tissue here. And this patient has pancreatic adenocarcinoma. So this mass, I reported this CT, it was possibly invading the spleen, invading the left kidney. The pancreas, unlike the liver, has no capsule. So it tends to invade. And because it doesn't have a capsule, it's not really confined to anything. So often at the time of diagnosis, it's too late. Like it's already started to cause problems that make it an unresectable cancer. And you're kind of stuck with chemo. And these patients, I forget the life expectancy, but it's around 6 months from diagnosis. It's a pretty bad one to get. It was invading the splenic vein. So that was clotted off or thrombosed. Known diet-related risk factors, so diabetes and obesity for pancreatic cancer, and as with many cancers, obviously smoking is a no-no. And this patient also has fatty liver. And then this thing here, this is a mass, so it's a darker, sort of circle in the liver. This is a metastasis. So this patient had metastatic disease at presentation from the pancreas, just to show how bad this disease can be. And then if you look at other parts of this patient, lots of calcium from heart disease at only age 56, malabsorption pattern in the small bowel, and lots of visceral fat kind of interspersed between loops of bowel. So that's this guy. Unfortunate case for sure. And then we've got this gentleman who's a bit older, cancer of unknown origins. So last time I checked his imaging, we don't know where these metastases are coming, but this is an image from a bone scan. So you can see, obviously, this is a skeleton, and hot spots, so the darker spots on this scan, show increased bone activity or bone turnover. So a lot of what we're seeing here is just arthritis in an elderly gentleman, but some of the asymmetric spots, you can see these, this is in the proximal or the upper femur. These spots are abnormal. This is definitely should not be there. This spot in the rib is probably abnormal. This spot in the rib on the back is probably abnormal. He's got spots in his shoulder blades here that are probably abnormal. And I know this one here in his clavicle or collarbone on the right is abnormal. So these are bone metastases. So whatever cancer he's got is spreading to the bones. And I'll show you, this is now a bone window CT scan. So just to explain where we are, this is kind of through the level of the shoulder. So this is a part of the shoulder blade called the acromion, which produces the tip of the shoulder, the point of the shoulder, and this is the end of his collarbone on the right, the clavicle. And this sort of gray thing is a soft tissue metastasis to the bone that's chewing up and destroying the bone. This is his sacrum now through the pelvis. And again, you can see this big hole being chewed into the bone here. And this mass is actually invading into the presacral space in the pelvis as well. And then I showed you those sort of upper femur spots. This is a little tiny guy, but this is an abnormal sort of hole in the cortical bone of the femur. That's also a metastasis in him. And this is a sagittal look from the side at his lumbar spine. Again, very subtle, but little holes being chewed into the bones here, mixed sort of sclerotic and lytic change in this vertebra here from metastases as well. So that's kind of what we're picking up on the bone scan. And he also had signs of intestinal malabsorption. So this is what I was talking about earlier. We call it misty mesentery. So this is the fatty mesentery of the intestines. We've got some blood vessels running in there, bringing blood back from the intestines to the liver. And it's sort of a more hazy or gray appearance. It should look more like this, like clean fat, but this is a hazy appearance of the mesentery because of fluid and inflammation from his gut malabsorption. And then again, this is a bit, difficult to spot, but he had sort of fatty stool, low density stool throughout his colon. So it's another sign of malabsorption. He's not absorbing fat from his intestines, and it's ending up in his colon. Like, this is the sigmoid colon. So this is basically on its way out. So no real time to absorb any of this stuff. So these are signs that he had of malabsorption. And then we look up at same patient's chest. He's had a sternotomy, so where they saw open the center of the sternum, the chest, crack it open, and they do a bypass. He's had heart disease. So I didn't show the calcium in his blood vessels, but he's got grafts. So these are actually internal mammary grafts. They've taken his native internal mammary arteries and used them to supply blood further down from the blockage in his coronary artery. So these are the two grafts that this guy has, and they use these metal wires to kind of, wire his chest back shut. So, like I said, these patients that we see, they've just typically got this sort of constellation of the same problems over and over again.
Yeah, do you think, can you have concurrently malabsorption as well as leaky gut at the same time? Can those two things run together?
Yeah, I mean, it's dysfunctional gut. I mean, I'm not an expert in leaky gut by any means, but to me, it makes sense. If you've got a membrane that is responsible both for bringing in things that you need and keeping things out that you don't want, I would presume that if it's an unhealthy intestine, both functions would be problematic. So you're no longer absorbing things you need and letting in things you don't want, while going both ways,
Yeah, and that makes sense. And I think the point you brought up at the beginning is, and most people don't realize that, we think that our alimentary tract is internal to our body, but it's actually the largest, it is the largest interface we have with the external environment. Our skin, as we know, but our skin is designed not to let things in. But our gut, we're supposed to absorb our environment through our gut. And when we're constantly exposed to the wrong things via diet, particularly the sort of industrial processed food diet, that's our largest interface. And we have the majority of our immune system sort of is built within the gut. Yeah,
for sure. There's a huge component for sure. And then there's the whole gut brain axis, that's a whole other, topic. So, and, that's driving people's behaviors. There's even I forget, it was a systematic review or something that meat-based people that eat meat have less mental health disorders than people who don't, So it's kind of like, well, is it contributing even to psychological, psychiatric disease as well, and that's all from our gut. It's from what we put in our bodies. So that saying that, you are what you eat. It's becoming more and more true as we discover, I think.
Yeah, maybe the last minute, because you obviously have alluded to the fact that you've been pursuing a carnivore diet. How did that evolve, and how's that affected you personally?
Yeah, sure. So, the biggest change for me was, like I said, those struggles with food focus and this sweet tooth. So now, like, hunger's gone, dieting is easy. I didn't even actively diet. All I've done since January 2020 is eat when I'm hungry, and I eat a nose to tail approach. So including organs, including, steak, of course, marrow, that kind of thing. And I've pretty much effortlessly lost 20 pounds. And, the past me to do that was like pulling teeth. It was like a gargantuan effort just to count calories, count macros. I was miserable, hungry, sleep was suffering. So that's all been amazing. Energy levels have gone up, my ability to work out, I was getting gassed in 2019. I had fallen to the sort of plant-based propaganda and was starting to reduce animal products and increase plant products. And I've never felt worse, Sean. I could barely go half an hour in the gym and then I'd just be gassed, and my sleep was suffering. I've got sleep apnea as well. That was getting worse. I was having difficulty, focusing on my work. And that all reversed in a matter of days, actually, within starting carnivore. And it's actually just progressively gotten better and better with time. My weight now is not really changing much, but I can see, my belly is not really sticking out anymore. I'm starting to see some ab definition. Gym continues to go well. I feel great. My sleep is better. I've had skin issues, some acne earlier in life. I've had this sort of itchy scalp my whole life. That's gotten better on carnivore. I'm a lifer. I don't think I'm ever going to go back. At most carnivore-ish, maybe adding a few things here or there. But right now, I feel my best when I eat just meat, fat, and organs. So I'm fully behind this. And I'm really glad to see that you're doing research on it, because I think that's really what we need to sort of convince the unconvinced, is to show them. Because every time I talk to my MD colleagues, are like, oh, where's the RCT, dude? Like, we can't, it's so hard to reason with them because they don't want to believe anecdote even from, one of their friends who's had, I have like medically diagnosed problems. Like I've got obstructive sleep apnea, and that's better. So I'm looking forward to doing that, and anything I can do to help from an imaging perspective. I've got a colleague, actually, he's very into the primal paleo lifestyle. He's very meat based as well. He actually helped me put together some of these images. Anything we can do to help further this movement and show people that they can recover their health and prevent a lot of suffering eating this way. Like, I'm happy to contribute myself.
Yeah, and I appreciate the offer. And certainly it's the more physicians that sort of just kind of objectively just step back and kind of sort of realize that what you said at some point, we don't know it all. There's a lot of stuff out there that we're still finding out. And the deeper we look, the more complicated we see it is, unless we really ultimately know. I mean, I see this time and time again. And so, when we see these just undisputable results, whether they're personal or patients we see, or, and I've got literally thousands of people now that have all said the same thing. So it's hard to ignore that. And yes, Absolutely. We will be getting some data. I mean, Harvard's got a study that's going to be published hopefully by the end of the year, maybe early into next year. We'll hopefully get this clinical trial funded and off and running, in the relatively near future. And I think it'll lead to more. I mean, I think there's just too much compelling evidence already that's driving it that way. At the very least, we should test it out, scientifically, thoroughly, and come to some conclusion with that. But
yeah,
so for people that would like to learn more about what you're doing, social media wise, where you could get contacted, because this has been very fascinating, and certainly I see some of the things that Dr. V. Khan on Instagram looks like, and Carnivore Roundtable. What's a Carnivore Roundtable, by the way? That's the first I've heard of that.
Sure. Yeah. So that is basically a podcast. So very early on, I went to sort of a meetup, MEAT meetup in Toronto, and I met some other carnivores, and we all kind of connected, became friends, and we just, some of them are ex-vegan, some of them weren't necessarily on a plant-based diet, but they've all of us have encountered healing. So, I'm the MD on the panel. We've got a functional clinical nutritionist as well. We've got just some, regular people that have also just experienced great things on carnivore. And what we do is we do an episode, maybe 1 or 2 per month. Sometimes it's a story of healing. Like, we brought in a family who was treated by paleomedicina for celiac disease and a variety of other things. They tell us their story, what they went through, the journey of healing. And then we also bring in experts. So we've had, Dr. Yoganathan on to discuss sort of GI-related disease. We talked about cholesterol and lipids. So we just try to put out a topic, and it's a discussion format. So we kind of go back and forth with the guest expert, asking questions, explaining our own experience. So if people want to find us, I mean, we've got an Instagram account. We're fairly active there. Our episodes are mainly published on YouTube and Facebook, but we do announce that on Instagram when those posts are coming up. So that's just at Carnivore Roundtable. And if they want to find me, I mean, I do post some stuff that is diet related on my personal Instagram. There's some other stuff that's more like, general, life advice, life help. So there's some car stuff. I'm kind of a car enthusiast. So if people want to connect with me directly, that's probably the best place to find me.
All right, perfect. Well, Dr. Khan, this has been an absolute pleasure. Thank you so much for taking your time on a Sunday to do this. And perhaps we'll get you back on down the road, and certainly we'll continue interacting. And this community is very, I think, fortunate to have benefit from your expertise. So thanks again, and appreciate it very much, and look forward to more work from you.
Yeah, you're welcome. And thank you for the opportunity. It's been awesome to be here. And as you can see, I'm very passionate. So happy to be back anytime.
Awesome. All right, everybody, you guys enjoy your weekend, and we'll see some of you guys tomorrow. Take care now. Bye-bye.